first speaker today is going to be Dr. Jayson Marwaha. He is a minimally invasive surgery fellow at the University of Michigan. During his residency, he completed a postdoctoral fellowship in surgical AI, where he built, deployed, and evaluated surgical AI systems at large academic medical centers and studied physician AI interfaces. His most recent research focuses on how physicians and AI can collaborate for better decision-making. Today, he's going to speak on the ABCs of ChatGPT, chatbots.
Welcome, everyone. Thanks, Dr. Walsh, for the introduction. It's a pleasure to be here. My name is Jayson Marwaha. As Dr. Walsh said, I'm the Minimally Invasive Surgery Fellow at the University of Michigan. And I'm excited to talk about this topic because I've been fascinated for many years with the idea of using AI to help with clinical decision-making, especially in surgery. I have no disclosures. I will be mentioning many commercial products during this brief talk because that's sort of the space where the majority of the innovation is happening as far as LLMs go. However, I don't endorse any particular products. And I do want to very briefly go out of order for a moment and thank my mentor, Dr. Gabriel Bratt, who might be in the audience. He's a trauma surgeon and AI researcher at BIDMC in Boston. And I want to thank him for many of the conversations we've had over the past several years that have informed a lot of the ideas that went into this presentation. So I was tasked with giving an introduction to chatbot tools that all surgeons have access to right now. Now, the reality is that there's a lot of heterogeneity in what health systems have implemented and what each of you in the audience have access to through your own institution and through your electronic health record. So for the purposes of this presentation, I'm just going to focus on direct-to-consumer or direct-to-clinician tools that all of you have access to right now. And the other objective here is that I don't want to tell you too many things that you probably already know. As the Slido at the very beginning showed, over 80% of you, I think, have used chatbots before for clinical purposes. And more broadly, ChatGPT they've reported that OpenAI has reported that they have over 700 million unique weekly users. So there's probably a good chance that even the 20% of you that haven't used it before have at least heard of it. And so I wanted to go beyond just mentioning the tools out there and their capabilities and also introduce some ideas around how we should be thinking about using these tools as well. And I think a good place to start when thinking about how to use LLMs is with one of my favorite stories of computer-aided decision-making, which comes from 1997, from a chess match between Grandmaster Garry Kasparov and IBM's Deep Blue algorithm. It was the first computer algorithm to beat a chess grandmaster. And after he lost this game, Garry Kasparov began to think very deeply about how humans and computers can collaborate. And he started to teach chess online with the help of computers. And in his teachings, he began to notice something very, very peculiar, which is, on his teaching platform, he had expert chess players and novice chess players. And when he introduced a very well-validated chess algorithm as a co-pilot for all these players, he began to notice something very interesting, which is that expert-ranked players that were paired with this computer algorithm all of a sudden began losing chess matches in large numbers to weaker players who were collaborating with the same exact computer algorithm. And in one of his talks later on, he describes that this might have been because he noticed a lot of friction between the expert player's very strong sense of intuition versus the computer algorithm's recommendation. And he said that friction may have altered gameplay of these experts in kind of unpredictable ways and often, clearly harmful ways as well. And now I think that observation is very relevant to the clinical use of large language models and chatbots for two reasons. First, you turn the story into one about clinical care and care of patients, and all of a sudden, we, providers, become the experts that Kasparov is describing, whose intuition has to confront these tools, and whose decision-making stands to worsen if we don't use them effectively. And then the other reason why this is relevant is because the world, even beyond clinicians, is increasingly using these tools not just to automate mundane tasks like writing emails for us and things like that, but also as cognitive consultants. So last week, OpenAI, the maker of ChatGPT, released an analysis of how the world uses ChatGPT, showing that we're using these tools more and more for purely cognitive tasks, not just to automate mundane tasks like writing for us as well. And this is true in medicine too, as companies sort of race to not just build ambient scribes and things that can automate documentation for us, but also to build the best cognitive consultant for clinicians as well. And so I want to touch on 3 categories of models in this space. And so, so I want to start by covering tools that are available to everyone. Like I mentioned, there's 3 categories. There's foundation models, medical language models, and agentic models. And so I'll start by talking about foundation models, which are large language models that are trained on vast generalist data sets that can be applied across a wide range of use cases. And you've probably heard of many of these before. OpenAI's GPT, Google's Gemini, Microsoft's Copilot, Anthropic's Cloud. Also there's DeepSeek and Meta AI's Llama model, a family of models. All of these models are trained on a massive corpus of internet text from sources like PubMed, as well as the preprint server archive, Wikipedia, GitHub, and much more. And for providers, at least, they have a kind of common core set of capabilities. You know, you can ask them general clinical questions. They certainly can automate some writing for you, like patient handouts and pre-authorization letters. And they can kind of do a modest job with these on these tasks with sort of the generalist training that they have from the internet at large. They do have some differential capabilities as well, like Google's Gemini model can perform an exceptionally deep analysis on certain topics for you with its deep research feature. Many of these models have multimodal capabilities, so they can do sort of image generation as well, or text to navigate between text and images. Microsoft's Copilot and a few of these other models can also generate statistics from tables as well. But I want to highlight 2 unique features of 2 of these models, and that's the DeepSeek model and the Llama model. These are unique in that they're both open source models, which means that the actual inner workings of the model are accessible to users, not to a point where the inner workings of the model are, say, comprehensible to a clinician, because many of these models have billions and billions and billions of parameters, but at least open source to a point where they can be interrogated, by a scientist. This is in contrast to some of these other proprietary models where we know the inputs of the model, like our prompt, the output, meaning like what it gives back to us, but essentially nothing else about what's going on in between. Another unique feature about DeepSeek in particular is that it exhibits similar performance in clinical domains to many of these other proprietary models, but is much less computationally expensive to train and to use, meaning it can be run, say, on premises at a healthcare facility instead of having to send queries back and forth from the cloud, which, as you can imagine, is very, very attractive for healthcare for privacy reasons and cost reasons as well. But generally speaking, I would say the consensus is that there's no one universal best foundation model for clinical purposes. Before I skip ahead. So these foundation models are what your patients are using to get clarity on their radiology reports and their new diagnosis or the conversation they just had with you. And if I was giving this presentation just a year or 2 ago, these are the models that us providers would be focusing on too. But for clinicians, within just the last year or 2, a new category of much, much more powerful medical language models has emerged as well. And the biggest player unequivocally in this space is a model from the company Open Evidence. Now, Open Evidence has seen astronomical growth over just the last year. They say that within the last year, 40% of US physicians regularly use their tool. Now, what is Open Evidence? Well, and what defines this new category of medical language models more broadly? Well, fundamentally, they're the same technology. They're LLMs, but they are LLMs that use a newer information retrieval technique called RAG, or Retrieval Augmented Generation. What that means is that they're not trained on medical text themselves, but instead they reference a massive corpus of constantly updated literature to give you an answer when you ask it a clinical question. And evidence from the computer science literature has shown that this new technique called RAG can reduce hallucinations, not eliminate hallucinations, but reduce them, and also, importantly, give you clinical answers with citations to real literature, which is very helpful for clinician use. Now, open evidence, if you haven't used it before, you can use it for free if you have an NPI number. They say their platform is HIPAA compliant, but I would check with your institution first before you start uploading patient information to it. In short, its capabilities are extremely vast. You can ask it for evidence from the literature, ask it for curbside consults from an AI specialist, so you can have it write materials for you, calculate a risk score, much more. And it's also worth mentioning that one of the other big players in this space is from Doximity, which you've probably heard of as well. They just recently released Doximity GPT as well, which has roughly similar functionality and capabilities to open evidence and is also free for providers. However, there aren't any head-to-head studies between these two models to get a sense of where they outperform the other. Now, these systems face many of the same challenges as foundation models, and because they're fundamentally the same technology, they exhibit a lot of variability in the responses or non-determinism. They can sometimes be sycophantic in the responses that they give you, depending on how you ask the question. They're certainly still susceptible to hallucinations, but one of the biggest limitations of these models is the near total lack of transparency. We essentially have no insight into how these models work, and as an example, in a recent Reddit discussion last year with the open evidence founders, one of the users asked, what LLM underlies your technology? And unfortunately, the answer that was given from one of the founders was unfortunately quite cryptic. But that's truly, sadly, the limit of what we know about these tools. It's also unclear to us what corpus of medical text that they have access to in giving us clinical answers. Another important late-breaking update I should mention is that just last week, UpToDate entered the spaces of medical language models as well with UpToDate AI, which presumably works the same way as these other models like Doximity and Open Evidence, but unfortunately is similarly opaque, and we have yet to see how this will affect the dominance of these other players in the space. So I've mentioned foundation models, medical language models. There's a third emerging category of agentic or multi-agent systems as well. Very, very briefly, agentic tools, very loosely defined, are ones that can interact with the real world in some meaningful way. For clinical purposes, this might take the form of Google Research's AMI model, which is still under development, but is a tool that can conduct full diagnostic interviews with patients. Another example might be Hippocratic AI, which is an agent that can call patients preoperatively and postoperatively. And then there's also multi-agent systems. So it turns out that if you take a bunch of agents, an ensemble of multiple models, and have them exchange information amongst themselves and converge on an answer, then that answer is actually much more reliable than just conversing with one large language model. And there's some examples of this that have recently come up as well, but they're still under development. So those are the groups of LLMs: foundation models, medical language models, agentic models. I want to end on a few brief words of caution around using these tools. The capabilities of all these tools is moving incredibly fast on really a day-to-day basis. And as a result, there's a lot of unaddressed concerns that I've mentioned, like hallucinations and transparency and also liability, that don't yet have answers. But I wanted to pick out two of the most relevant considerations for use for end users like us. The first is that as it relates to clinical decision support, we're starting to see this phenomenon I described at the beginning of user versus model friction that Kasparov described in 1997 start to reemerge. This is a paper where physician specialist experts were given complex cases from the New England Journal of Medicine. Their unaided diagnostic accuracy was 74% on these very complex cases. When they were aided by a large language model, their diagnostic performance was roughly the same, actually at 76%. But the large language model, unaided by a human or unencumbered by a human in some sense, had a diagnostic accuracy 16 points higher at 92%. So what does that mean? Well, what that presumably means is that the limitation is not on the model's power or the model's accuracy, but instead on the human trying to figure out how to weave its recommendations into our own internal decision-making processes. And then the last consideration I'll leave you with is one of perception versus reality. So, and our perception of these tools as we use them of chatbots as we use them for automation, for writing pre-authorization letters and drafting responses to inbox messages and things like that. This is actually a study from the software engineering literature where a bunch of software developers were given a coding task and also an AI coding copilot. They were given the Anthropic chatbot to help automate their coding. And after they completed the coding task, they were asked, how much time did you save by using this, the Anthropic's AI coding copilots? And they loved the tool and they said, oh, it saved me on average 20% on my coding tasks. But when the researchers actually looked at the time logs, it slowed developers down by 19%. And so I think this highlights the very interesting evolving big gap between our perception of the utility of these tools versus the reality of if and how they truly add value in our workflow just yet. And so the bottom line is this: I think the capabilities and the options for these tools is rapidly expanding, day by day, as I mentioned, and really that's not the rate limiting step in the progress of this technology. What is instead is that no matter how much more accurate or powerful these tools get in giving us the right clinical answers, many of these fundamental challenges remain the same, like how we need to figure out essentially how to incorporate them effectively into our clinical judgment and our intuition. And so I encourage everyone to explore these tools because their potential is very hard to ignore, but to keep two things in mind. One is that these tools are far from perfect, even though they're getting better and better, but almost more importantly, our understanding of how to collaborate and meaningfully interact with these tools to improve our decision-making is far from perfect as well. Thank you.
Our second speaker